Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interaction.
So welcome everyone to this month's podcast from Neurogastroenterology and Motility. My name's Adam Farmer and I'm a gastroenterologist at the Wingate Institute in London. This month it's my great pleasure to welcome Dr. Arjan Bredenoord. His current position is at the Department of Gastroenterology at the Medical Centre in Amsterdam. His primary research focus is on esophageal physiology and pathophysiology, on which he has published in excess of 150 papers and several book chapters. So Arjan, many thanks for joining us on the podcast today, and congratulations to you and your co-authors on your paper entitled Diagnostic Yield of 24-hour esophageal manometry in non-cardiac chest pain. So if I could start, could you give us some background to the clinical entity that we know as non-cardiac chest pain?
Thank you, Adam. We refer to non-cardiac chest pain when there is a midline chest pain or discomfort that's not of burning quality, to differentiate it from heartburn, and it has not been diagnosed before as due to ischemic heart disease. So these are patients with discomfort or pain. Often they're scared because they don't know what the causes of their pain, and it's quite typical that the pain comes in attacks. So it's not constantly present, but it comes and goes. It can be very invalidating and frightening to the patient. And a positive diagnosis is very helpful. So the patients, you need a diagnosis, an explanation for the symptoms of the patient, and also as a starting point for treatment.
So, what are the putative pathophysiological mechanisms that give rise to symptoms in this patient group with non-cardiac chest pain?
So, our data shows that about 30% of these patients has gastroesophageal reflux disease, and another 8% has so-called hypersensitive esophagus. So, in these patients, reflux is also the cause of their symptoms, but they don't have excessive amount of reflux. Now, the biggest bulk of patients, 50%, has functional pain. So that means that we don't know what the cause is of their symptoms. And 7% of the patients has esophageal spasms. So similar to other functional disorders, we don't know what really the cause is in about half of the patients with non-cardiac chest pain.
Yeah, this is something we've studied in our own lab in London and found certainly that many of these patients have the personality trait of neuroticism particularly is overrepresented in this group. So you mentioned a little bit about esophageal spasms. So why does standard high-resolution manometry fail to pick up motor abnormalities in the standard clinical workup that we would use in secondary care?
So one of the reasons is probably because the pain comes in attacks, and between these attacks there's no pain. Now the chance that a patient will have an attack during the 30 minutes lasting stationary manometry is really small. That's one explanation. Also, the diagnostic criteria for spasms have become rather strict according to the Chicago classification 3.0. And while 3 out of 4 patients with spasm on ambulatory manometry have some kind of abnormality on HRM, this didn't classify as a spasm according to this the newest version of the Chicago classification.
So what were the objectives of your study?
Well, ambulatory manometry is not widely available and it's not often performed. We wanted to investigate the additional value of ambulatory manometry to the workup of these patients with HRM and ambulatory pH impedance monitoring.
And what were the characteristics of your patients in your study, and what methods did you use to go about studying these patients?
So we studied patients with non-cardiac chest pain, and these patients previously underwent a negative cardiac and GI workup, all tried PPI before, and we studied these patients with stationary HRM and ambulatory manometry pH impedance monitoring. And then we investigated what the additional yield was of the ambulatory manometry in comparison with all the other investigations.
And how long was your ambulatory manometry?
24 hours,
Okay.
approximately.
And what were the key results then to come out of your study in this patient group?
Well, in 4 of the 59 patients that were studied, ambulatory manometry identified spasms as the cause of their symptoms. This is not a very large proportion, but for these patients it's a really important finding. Also, as I just mentioned, in about 50% of the patients it was concluded they suffered from functional chest pain, which is also a very important finding.
And what were the limitations of your study, do you think?
Well, the study was retrospective, and hence it's subject to bias. Also, bias because of the information collection from the electronic patient records, but also referral bias may be significant, as the study population are all from our center, which is a tertiary referral clinic.
So what do you think are the take-home messages for clinicians coming from both your study and as a whole?
Well, I think there's two very important messages. One is, in case of non-cardiac chest pain, consider referring for ambulatory manometry, pH impedance monitoring. And the two is findings of on HRM, such as repetitive contractions and rapid contractions, are now in Chicago 3 not classified as abnormal, but they may be an indicator of spasms.
And taking that slightly one step further, if spasms are found, what do you find in your own clinical practice is the best way to treat these patients? What pharmacotherapeutics do you personally use?
If we have a stepwise plan for treatment, first we try with calcium antagonists or nitrates. It depends a bit. If the patients have very rare symptoms, sometimes nitrate sublingual or a spray is very helpful. If their symptoms are more prevalent, sometimes a slow release formulation is better. If this doesn't work, we try Botox, and in very rare cases we have performed endoscopic myotomy. But I must admit that the symptoms of the results of that technique are not successful to all.
Okay, have you ever tried sildenafil in these patients at all? There are a few reports from Mark Fox regarding this.
Yes, I've tried it in once only. The problem with this drug is that it's not reimbursed, not for this indication or other indications. That makes it quite expensive to the patient.
Yes, no, that's my experience here in the UK as well. So, just summing up, where do you think the knowledge gaps lie in the field of non-cardiac chest pain at the moment, and how can we begin to resolve these as we move forward?
I think the biggest knowledge gap, the biggest problem, is the patients with the functional chest pain. So we have no clues as to what causes their symptoms. We only have, there are some indications, but basically we don't know, and there's hardly any data showing how to treat these patients. So I think more pathophysiological research into the mechanism, peripheral and central, would be very helpful, as well as trials investigating the treatment for these conditions.
Super. So thank you for that, and with that I'd like to thank both you and your co-authors for a really excellent paper, as well as assisting in this month's podcast, and also to our listeners for tuning in, and I look forward to welcoming you for another instalment next month.
Further information about this paper can be found on the journal website. We hope that you have enjoyed this podcast, and we look forward to welcoming